Hello, and thank you to Leigh Day and to all of you here today for being part of this vital conference tackling inequality in women's healthcare. What I'm going to be talking about today is a hidden taboo. Obstetric anal sphincter injuries affect 1 in 50 women in the UK. It is a secret epidemic. Also known as severe perineal tearing, these injuries do not just cause bowel incontinence, but other pelvic floor dysfunction, such as urinary incontinence, dyspareunia, which is pain during intercourse, perineal nerve damage, pelvic organ prolapse, and rectovaginal fistulas. The Masick Foundation is the only UK charity to support women who have suffered these severe injuries during childbirth. I want to share with you today my lived experience to give you an insight into the challenges women face to get adequate care for these devastating injuries and how cultural issues can impact this. The injuries I sustained during the birth of my first child still impact me every day. That was over 14 years ago. I was 30, at the height of my career as a catastrophic injury lawyer. I was recently married and excited to become a mother. Life was good. I had a normal pregnancy, but although I was of Asian heritage, no one had discussed with me the increased risks of perineal trauma due to my ethnicity. Asian women have the highest risk of 3rd and 4th degree perineal injuries. I went into labor on a Sunday night at a busy teaching hospital. My attending midwife had an inexplicably hostile attitude. It was clear my labor was not progressing as expected. Any requests to discuss the deteriorating situation were met with increased irritability until there was marked fetal distress, and what followed can only be described as a nightmare. Panic ensued, and there were several failed attempts at ventouse and an extremely traumatic forceps delivery that left my daughter with permanent injuries, and I sustained a 3C tear involving the entire length of the internal anal sphincter and external sphincter. I experienced my first episode of fecal incontinence the very next day. From this episode to date, I continue to be completely incontinent of feces and flatus, have marked fecal urgency, passive fecal incontinence, urinary incontinence, and perineal pain. Once discharged, I saw my GP several times. He was empathetic, but never had any answers. And sadly, never once suggested referring me to a perineal trauma clinic. I don't think he knew they existed. The only place I was referred to was Urogynae, and I was simply told to do pelvic floor exercises. I went from being a resilient, independent woman to needing significant help from my husband, in pain and having frequent bowel accidents. This only compounded my feelings of anger and horror at what had taken place. I struggled on, but several months after, the situation was so dire, I moved in with my parents for support. I'm from an Indian family that have high expectations of achievement, and the fact that I could not cope with the severity of my symptoms and being a new mother made me feel like a failure. These profound feelings of inadequacy were a significant cultural barrier for me in seeking help. Every time I spoke to a healthcare professional about my injuries, but there was no help offered, it only served to reinforce my feelings of helplessness with my situation. So eventually, I just gave up. I was hoping to apply for partnership at my law firm on my return to work, but I couldn't even make it through the day without having repeated bowel accidents. It was only because of circumstance that I managed to get help. My mother, a pediatrician, researched and pushed for me to get referral to a perineal trauma clinic. Only once I finally underwent extensive endoanal investigations, I was told for the first time how serious my injuries were, involving pudendal neuropathy, and that my poorly attempted repair had completely failed. It was horrifying to hear, but also a relief to finally understand why my symptoms were so severe and debilitating. That was in 2010. Since then, I have undergone further surgery, suppositories and enemas, anal plugs, rectal washouts, medications, biofeedbacks, the works. But I simply had to adjust the way I lived to cope. I've lost precious years of normality, my career that meant everything to me, and the ripple effect on my family and friends has been huge. I wanted to tell my story firsthand to explain the difficulties I and thousands of women face trying to get adequate care for OASIS injuries. It was a battle. And that was despite being born in this country with a supportive family and a sound knowledge of the medical system. Now, imagine being a first-generation immigrant with a poor grasp of the language, no real family support, and having your first child. The cultural, language, and structural barriers to accessing adequate care are insurmountable. This is exactly what happened to Rani, a tremendously brave woman I met through the MASIC support group. Rani moved to this country in 2014 from India with her husband. She was excited about a life full of opportunity. Her husband was very traditional and at times controlling, but Rani was an optimist. He was keen for a large family, and she quickly fell pregnant with her first child. Rani's English was very basic. Her husband was fluent in English and attended every antenatal appointment with her. Vital healthcare discussions were often directed towards him, without checking to see if she had understood. No translator was ever offered to her. Rani had little support from her husband during her labor and was not able to communicate properly with her midwife. After a prolonged first stage, she managed to share her concerns and ask about options. She was abruptly told that a C-section was not going to happen. It might happen in other countries, but it would be of great cost to the NHS. Rani felt belittled and as if she should be grateful just to be here. This individual interaction with her caregiver, even as a consequence of implicit racial bias, at a time when she was at her most vulnerable, had a huge impact on Rani. She didn't ask for help again during her labor. Eventually, there was an instrumental delivery, but she was distressed and didn't understand the consent process. She didn't recognize words such as forceps. Rani sustained a 4th-degree perineal tear, which was unfortunately not diagnosed. Once home, Rani experienced severe incontinence and was in chronic pain. Her husband was a domineering presence at both her health visit and 6 weeks check. Discussions were again mainly through her husband and focused on her baby and breastfeeding. Rani was told about child health clinics and Sure Start centres, and it was assumed by her health visitor that she would understand their purpose. She didn't. She was crucially not offered a separate postnatal checkup for herself and asked about whether she was experiencing incontinence. After several months, she was desperate and built up the courage to go alone to her GP. She asked to be examined by a female member of staff, so was shocked when her appointment was with a male GP. She couldn't discuss her pain on intercourse or fecal incontinence with a man. She felt ashamed. Her husband grew impatient, then angry, then violent, that she could not return to a sexual relationship due to her injuries. He wanted her to have another child, but she couldn't imagine going through that trauma ever again. Rani was scared and isolated. She didn't know where else to go for help. She had never heard of this condition in India, and no one talked about it in her community. She found leaving the house in her traditional dress, a sari, and having repeated fecal accidents too difficult to manage. She lost her job. She was not able to even attend her local temple. Temples are considered spiritual places, and it is traditional to use the toilet and bathe before entering. She was considered unclean. She couldn't risk having a bowel accident there. It would have brought shame on her family. She just accepted her symptoms as part of having a baby. She became invisible. There were so many missed opportunities to help her. Had her postnatal appointments been culturally sensitive, Rani could have been signposted to information in her own language and specifically told about groups that offered support from the same background and culture. Her silence was taken as permission to ignore her. Cultural assumptions were made. She was quiet because she was from a different country. She didn't know the language well. It was never questioned further that actually she was suffering and that she faced a huge stigma talking about her fecal leakage, especially in front of her husband. She was dehumanized. The failure to recognize language difficulties is an overwhelmingly discriminatory factor in maternity and ongoing care. Simply assuming a woman's partner or family member will translate or pass on vital information leads to a lack of choice about maternity care and a lack of informed consent, which is a basic and fundamental right of every woman. Rani didn't have a voice in her labour, which subsequently hugely affected her confidence in seeking care for her perineal injuries. Had her simple request to be seen by a female GP been listened to, Rani may have felt able to talk about the recurrent infection she was getting, her fecal urgency and pain. GPs are the gateway to so much vital healthcare. Their role in providing culturally compassionate care is essential. After several years, Rani finally accessed a referral to St. Mark's Hospital. Subsequently, she had surgery and a stoma fitted. 35% of women who have a fourth degree tear have to face a stoma. However, she is still completely isolated from her community, whom she feels would not accept her with a stoma. I too felt isolated for many years. That is until 2014, when I became involved with a groundbreaking charity, MASIC, set up by a leading colorectal surgeon, Professor Michael Keithley, who's with us today. When Rani reached out to MASIC, we were able to introduce her to other women with similar injuries, and she has now built up a network of support. A recent survey by MASIC found that 85% of women who sustained severe perineal injury said it impacted on their relationship with their child, and 50% of women stated they were unable to do normal day-to-day activities due to their injuries. Suffering from fecal, urinary, and flatal incontinence has devastating social consequences for women. Self-esteem, the ability to socialize and work, physical intimacy, social isolation, economic deprivation, and comorbidity of psychosocial problems such as depression, anxiety, and stigma are all widely reported. Sustaining these serious and often permanent injuries causes huge inequalities for women of all ages and ethnic groups. But add to that language barriers, cultural stigma, and structural barriers, it is not surprising that women from ethnic minorities are slipping through the gap. MASIC itself recognizes and is addressing the fact that women from Asian and Black ethnic backgrounds are underrepresented in their membership, even though, as stated earlier, evidence shows women from these ethnic groups are at higher risk of severe perineal trauma. The fact that we still don't fully understand the reason for this is discriminatory in itself. It is just an accepted statistic. Culturally competent care depends on resolving systemic barriers and understanding individual cultural differences. Language barriers need to be urgently addressed. MASIC has produced leaflets on OASIS in several languages disseminated at GP practices, but interpreters and language services need to be used more frequently. MASIC is calling for a comprehensive assessment for OASIS injuries following all births, which will also help identify women who are less likely to report injuries due to cultural reasons. Female clinicians should be available for postnatal checks, and women from ethnic minorities deserve to be educated and empowered prenatally about their increased risks for OASIS injuries. Recruitment of a diverse staff and advisory body is essential, and training. training on discrimination and cultural barriers, training on preventing, repairing, and recognizing these devastating injuries. As highlighted by the groundbreaking work of organizations such as MASIC, the Motherhood Group, 5 Times More and Birthrights, there needs to be a call to action individually and within all of our own organizations to make women from ethnic minorities feel safe and heard within healthcare. In 2022, we can and must stop stories like mine and Rani from happening again and shine a light on this hidden taboo. Thank you.